good evening, and welcome to MS Views Now. This is a program by MS Views and News. It's a monthly program which we began at the beginning of the pandemic. It's COVID related, but tonight's program is not about COVID itself. All right, we have Dr. Gary Owens. I'll tell you about Gary Owens in a minute. First, I want to just remind everybody that I am Stuart Schlossman, president and founder of MS Views and News. I am also an MS patient, okay, and that's a totally different subject. Tonight's supporters are Bristol-Myers Squibb, Genentech, and Biogen. All right, we want to thank them. We always want to thank our supporters. So I'm going to let everybody know. Say thank you from where you are. We hear you. Okay? Yeah, right. Okay, next, we have Dr. Gary Owens. All right, and Dr. Gary Owens is a physician, a former Blue Cross medical director. He's going to tell you more about himself when he gets his program started. And he's going to be speaking today about the updates on today's insurance process, the authorizations, managing benefits, step therapy, and understanding specialty pharmacy. This is really, really much needed information for many people, especially myself, okay? I mean, I've been going through this whole crap with Medicare lately, and you just never know which one is the right thing that you're getting and what you're told you're getting, and then you find out, that's not exactly what I was told, and they're not paying as much as they should. So this kind of talk by Dr. Gary Owens is very much needed by myself, and I'm sure thousands of others, and I'm glad that you all are online to listen to his talk tonight. Please remember that Dr. Gary Owens cannot answer COVID-related questions, though. He's only speaking to you about this topic during COVID and how it would benefit you. All right, so if you have any questions, please remember to use the rectangle at the top of the toolbar. Click on that. If you have any questions during this dialogue, please write in your questions. We are going to let Dr. Owens speak for about 40 minutes, and then I will go through all the different questions. And we also have some on paper already. I will go through your questions that you asked online, and we'll finish out the evening by asking all questions for this program. All right, so let's get Dr. Owens started, and take it away, please.
Well, thank you so much, Stuart, for that kind introduction. And Bill, I know you're behind the scenes on all of this, and happy to work with you again. And for those of you in the audience, happy to be back joining Stuart and his group. And, tonight I'm really going to talk to you about some of the things that the pandemic has really created change, and some areas where it really hasn't changed that much. But as Stuart said, important information that you need to know. But as we move ahead, let me just tell you a little bit about myself. Very often in these programs, you have experts in MS, neurologists, MS treaters, those who run MS specialists, who bring you up to date on the latest developments in the treatment. And of course, I've also joined programs where you have people who talk about exercise and diet and all of those things. I take a little bit of a different approach. First of all, I'm not an active MS treater. I was a family physician for a number of years in the great state of Delaware, the second smallest state in the country. I transitioned out of that career to actually work with the Blue Cross system, and I was a medical director in Blue Cross plans for more than 2 decades. So I learned a heck of a lot about the insurance industry, how pharmaceuticals are managed, and I learned a fair amount about MS, and I'll get to that in just a moment, where that comes in. And for the last 10 years, I've gotten to do a number of things, including talk to folks like you, as well as do continuing education seminars for some national organizations, and really, do a wide range of things. And so what I have is both a personal and a professional focus on MS. Let's move ahead, and I can tell you what we're going to talk about, and then I'll tell you a little bit about how I got engaged in this. What we're really going to talk about first is the concept of specialty pharmacy. I'm sure all of you have heard the term, but I'm going to explain a little bit more about what it is and what you really need to know about specialty pharmacies and why they're out there. I also want to bring you up to date on some payment rules that are changing that could be very germane to you and getting the access to the pharmaceuticals that you need. And I title this Beware the Copayment Accumulator and the Copayment Maximizer, because they can fundamentally change your access and in terms of what you spend. And then I am going to talk a bit on a COVID-related topic, and that's telehealth. And telehealth has really changed the way we're practicing medicine. The movement to telehealth started well before the COVID-19 pandemic began, just a bit more than a year ago. But that, it was really the pandemic that really was the driving force to the growth of telehealth. And I don't think we'll be going back 100% to the pre-COVID era with that. So now let me tell you about myself and my interest in MS. And I'll do that with a family photograph. And the first thing you're going to notice right away, the guy sort of in the middle of the back row is me, but not the gray-haired guy that's speaking with you a while ago. This is a family photograph of my wife and our 6 children, quite a few years ago in a coastal location. And I point that out to also say there's an arrow over my son over on the left-hand side of the screen, who is an MS patient, although he wasn't at the time. So my personal relationship to MS is a son with MS. He's had the disease about 5 years now, and helping him navigate some of the issues around MS. My professional interest comes in the fact that one of the very first specialty pharmaceuticals, and I'll define that term in a minute, one of the very first specialty pharmaceuticals was indeed an MS drug, and that was beta interferon. And back in the early 1990s, when that hit the marketplace, the world was very different in terms of how prescription drugs were accessed and paid for. And suddenly this drug that for its time came along at the, quote, outrageous price of about $8,000, $9,000 a year, turned many systems upside down, literally in an era where drugs were 20, 30, 40, maybe expensive ones, $50 or $60 a month. We now had a drug that was, several $100s a month. So let's start by moving on to what is a specialty pharmacy. Well, in order to define specialty pharmacy, we really have to tell you a little bit about specialty drugs. And there's really nothing unique or special about them in terms of what they are. They're basically defined as high-cost prescription medicines. They're generally used to treat complex diseases, MS being one of them, rheumatoid arthritis being another, many forms of cancer. Most cancers are certainly complex unless they're in very, very early stages. And they're usually diseases that are chronic in nature. And you might say, well, wait a minute, is cancer really chronic in nature? And the answer is, for many cancers, yes. In 2021, with the onset of things like immunotherapies and targeted therapies in certain cancers, we're now seeing people, live 10, 15, 20 years with stable disease. So indeed, many of those have become chronic diseases. So what happened? Specialty pharmacies were created. And yep, we'll go right ahead to that slide. Specialty pharmacies were created basically to handle many of the unique issues that came up concerning these complex and expensive drugs. And what are some of those differences? Well, first of all, for the most part, for those drugs like MS drugs, you really can't take them down to your local drugstore, hand the prescription across the counter like we did in the good old days, whatever those days were, and expect the pharmacist to say, wait 10 minutes, wait 15 minutes, go do a bit of shopping, come back, and I'll fill your prescription. There are several reasons for that. One is, very often because of the cost of these drugs, they're not stocked in every pharmacy. Second is, because these are complex drugs, the payers, those who pay for them, have created specialty pharmacies to help not only handle the drug and dispense the drug, but also to really fill a number of needs that go along with these complex drugs. So let's take a look at what some of those behind the scenes interactions are. In order to explain, those behind the scenes activity, we have to explain, well, why did the specialty pharmacy get created anyway? Why couldn't you just put all these pharmaceuticals in the corner drugstore? Well, there's a number of reasons. One is they account for almost half of the spending on drugs now in 2020. In fact, these are data from one of the large national drug distributors, CVS Caremark, and 42%, that's really closing in on half of the spending, is for specialty drugs. But that 42%, that's almost half that pie over on the right-hand side, goes to treat diseases in less than 5% of the patients. So what does that mean? It means the other 95% of us out there who maybe aren't using a specialty drug only have that other half of the pie to be able to use for our drugs. So what you've seen in this drawing is meant to represent is also since 2010, yes, the pie has gotten larger, as all medical spending has, but the amount that's spent on those who aren't on specialty drugs has stayed relatively the same. So what does that mean? Is payers really look for better ways to more effectively manage these drugs, and also to recognize that they sometimes come with some complexities. You can't always take them with the same, you can't always take them with certain medications. You may have to avoid certain things like vaccinations when you're on certain ones of these drugs. Some of these drugs, especially in MS, may change your immune system and therefore predispose you to certain illnesses. And all of that was what led to the creation of the specialty pharmacy. So here's what goes on before you get your prescription. I'm pretty sure you're all familiar with prior authorization, essentially what's known as, the physician needing to get the permission from the payer before the drug is dispensed. And so what that really means is your physician, before they ultimately either write your prescription or after they write your prescription, before the pharmacist can fill it, the payer has to authorize that the drug is actually going to be paid for. That means that the provider is going to have to submit some basic medical information. What's your diagnosis, perhaps? What other medications have you been on? What other medications might you currently be taking that could your drug interfere with the activity of them? And also, based on the best evidence that we have to date, are you the best candidate for this drug? Many times, the physician tries to do the best job they can, but remember, they often deal with multiple insurance plans. I talked to an MS treater that I know well in New Jersey recently, and he basically deals with two public plans, Medicare, as Stuart has already alluded to, which can be a bit complex, Medicaid, which has state-level complexities, and 5 or 6 other insurance carriers. So they don't always get all the information that is needed the first time. So very often, the prior authorization process requires some back and forth. There's also another term that comes into play, and those are formularies. Formularies are basically just lists of drugs that are covered or covered at different rates by your health plan. And again, that's in an attempt to find the most cost-effective agents that are out there. And very often, if you are prescribed a formulary drug, you're going to pay less out of pocket. And I'll show you a bit more about that in a minute. On the other hand, if your physician prescribes a drug off formulary, you may have to pay more or have trouble accessing it. Let's delve into prior authorization a bit more, because there are really 2 types of prior authorization. The first one is pretty simple. It's one known as a soft prior authorization, and it is basically a provider writes the prescription for the drug, confirms that they're a prescription of the sort of specialty. In your case, it would be a neurologist or an MS neurologist that's prescribing the drug, and the drug gets approved. It's basically an attestation that my patient has MS, I'm a neurologist or run an MS center, and this is a drug I want. Okay, great scenario, doesn't happen very often in MS. More often, you as patients are into the world of the hard PA, which is basically the provider prescribes a drug, they then provide the information that's needed, the plan evaluates that information, bumps it up against standardized criteria that are developed based on the indication for the drug's label, what might be in the clinical trials for the drug, is the drug on our formulary, and then the drug gets dispensed. And I can almost assure you for your MS drugs, you're going to be in the world of the hard PA, which takes a good bit more time and may have a bit of back and forth. So you guys all know about prior authorization, and I'm sure because you've encountered it, many of you have encountered the fact that a prior authorization may take some time and also may be frustrating at times when you get that initial denial. But why are prior authorizations out there? Well, I think it's become obvious from what I've said that the goal of the payer is to ensure that plan members get a medicine that's safe, effective, doesn't interfere with their other conditions, and provides greatest value. And notice I said greatest value. There is the perception, and it's an easy perception to have, that prior authorization is just out there purely to save money. Yes, that is one goal of it, but it is not the sole goal. That's why these are in there. So let's move on. Formularies, why would you care about a formulary? It's part of the prior authorization process because usually prior authorizations get easier to go through if your drug is on formulary. But you say, well, I don't care about that. If I get my drug, do I really care about the formulary? Well, the reality is most formularies have what are called tiers, illustrated here on the left-hand side of the slide. And the higher the tier of your drug, and most MS drugs, unfortunately, or specialty drugs, there are a few adjunctive treatments to MS, things that may treat your symptoms that are going to be on, second and third, maybe even a fourth tier. But most of your MS drugs, the drugs used to directly treat you with disease modification, are on a specialty tier. The higher the tier, the more you may pay out of pocket. And then two things can happen. You may not be able to afford that drug, or your provider may have to give you a different drug. And so you can probably see now that getting through that process can take some time. There's no real rule of thumb, but according to regulations, and this is including the regulatory bodies that certify payers, as well as the federal government, payers are required to turn around complete PA requests within 72 hours and urgent requests within 24 hours. Notice the key word there is complete. Oftentimes, what information the provider submits is incomplete. For instance, they may have left out some data about what drugs you've been on previously. They may have left out some data about what stage you are in your disease. And so then there's a bit of back and forth between the prescriber and the payer. And that can sometimes take a week or two. Then there's even yet another step. And once the specialty pharmacy gets the prescription and gets the prior authorization, it can take another day or two to ship by overnight. And then there's yet one more complication. I'm sure you've all encountered this, and that shipping doesn't occur until member payment responsibility is met. So if you don't have a means to pay or you don't have a source of payment, then the drug is not shipped until there's payment confirmation by the specialty pharmacy. So let me give you one illustrative example, and then we'll talk about what to do if you disagree. This illustrative example isn't on the slide, but you might ask yourself, why did payers, pardon me, put in all these prior authorizations in specialty pharmacy? And indeed, I alluded to cost, and it's about managing the cost. The cost of medical care always goes up, never goes down. And what payers are in business is to try to match the most cost-effective drug with the best value they can get on your behalf. And in the end, that helps everybody's premium stay a bit lower, or if you're in a self-funded group, it helps your employer pay less out of pocket for your benefits, and therefore hopefully has more left over to pay you as employees. And a good illustrative example is, one that I can use. I think it's germane here. How about if my good friend had a program that said, look, I'm going to buy all of my friends a car. So you go out and shop for a car, and you can pay for it on my credit card. And I don't know much about cars, so I go to a car expert who's like the doctor in this case, and I say, what car should I buy? And the director goes, well, gee, really? If I were you, I would get a Ferrari because I'm a sports car buff and they're really fun to drive. Yeah, they're only, a couple $100,000, but since your friend's paying for it on his Visa card, uh, what the heck, at that point, don't you think my friend, now the proxy for the payer, would want to ask me some questions like, what do you really need that car for? What do you use it for every day? And I would say, well, I need to go back and forth to the grocery store and the drugstore, and maybe I go to visit my grandchildren now and then. And he goes, well, don't you think something else would be more appropriate? I know it's a crude example, but if you really think about the cost of MS drugs in a year, you're literally asking that payer to pay for the cost of a new car over the course of the year. So that's my kind of illustrative example of why this happened. And then finally, if we can just go back to that slide, I want to point out, just because a payer denies your prior authorization, you have the right of appeal. And that right of appeal is protected by state and federal legislation. So don't give up if you and your provider really think you have a right and need this specific treatment. Talk to your doctor. Get him and you can turn your benefit card over, or in Medicare, you go online to cms.gov. They tell you how to file the appeals, and you can literally file the appeal. And in commercial insurance, typically you have 3 levels of appeal. Believe it or not, in Medicare, you have up to 5 levels of appeal. Although if you let all those play out in Medicare, that could take months. So in practical purposes, the first 2 or 3 levels of Medicare appeal are where everything happens. So now let's move along to the next topic. This really dovetails very nicely with specialty pharmacy, because this is something of which you may not be aware, and is a development that's really within the last 3 years maybe or so. So let's take a look and talk about, what does the term copayment accumulator mean? Well, to understand what copayment accumulators mean, you have to understand that many MS patients like yourselves, even like my son, need some sort of cost-sharing assistance to be able to afford these very costly drugs. And these are some data taken from a national survey by the Kaiser Family Foundation not too far back, and it showed that almost 60% of RA patients, basically over on the left-hand side of the slide, need some kind of cost-sharing assistance, and about 50% of MS patients need some kind of cost-sharing assistance. So what we know is cost-sharing assistance is key and essential for many of patients to get access to their drugs. So what has happened in the real world? Well, what is cost-sharing first? Well, cost-sharing can be one of about 4 things, 3 of which mostly apply in MS. First of all, there's a deductible, and that deductible is defined in the terms of your insurance benefit. It's what you pay before your insurance benefit starts. A good example, I'll go back to the auto world. All of us have deductibles on our car insurance policy. If you're unfortunate enough to be involved in a little fender bender, you may have to pay the first $500 or $1,000 of the cost, and then the insurance kicks in. That's precisely what a deductible is. What is a copayment? A copayment in the health insurance world, it means a fixed amount you pay towards a service. So if you go see your primary care doc and that copayment is $25, you pay that, and the insurance company pays the rest of the bill. Or in the drug world, if your copayment is $20 and the cost of the prescription is $200, you're paying the $20 and your insurance company pays the other $180. Coinsurance is a little bit different, and people often get confused. In this, coinsurance is a variable amount, typically a percentage of the service. So use the example of the $100 drug. If your coinsurance is $25, you pay, or 25%, you pay $25. If your drug cost is $1,000 and it's 25%, you pay $250. So co-payments are a fixed amount. Co-insurances vary based on the cost of the drug. And something that doesn't typically apply in the drug or the medical benefit category where all the MS drugs lie are what are called benefit maximums. And that's the maximum amount towards a service that the insurance company pays. And those don't generally happen in the types of services. But in things like durable medical equipment, which many MS patients may need for assistive devices, you may run into the benefit maximum over there. You can tell I'm a little gravelly. It is pollen season in the mid-Atlantic. For those of you who live in this area, you know that virtually everything that's outside this time of year is yellow, and my voice inside is affected by that. So as we pointed out, MS drugs have a high cost. As demonstrated in the previous slide, out-of-pocket costs can be significant. Cost sharing came into play because we recognize that as long as 100% of your cost of anything, whether it's a medical service or anything else you get, if it's paid by a third party, you and your prescribing doctor may be well isolated from the cost of that treatment and therefore not become a part of informed decision making. So both Medicare and commercial insurers have cost sharing in them. For instance, Medicare Part B is basically an 80-20 plan unless you have supplemental, which means you have a 20% co-insurance in Medicare Part B services. Medicare Part A hospital, you actually have a deductible if you're admitted to an inpatient hospital. And there are services in Medicare Part A that have that benefit maximum I talked about. But these well-intended concept of cost sharing, or this well-intended concept of cost sharing in today's world where inflation of cost of all medical services, and especially in your case, MS drugs, it's created some barriers to care. Hence that data that showed that about 50% of MS patients need some sort of assistance. And so here's the unintended consequence. And again, these are data from Kaiser Family Foundation, just published in 2021. In the past month, based on affordability alone, this is not specific to MS, but medical care in general. 28% of people put off needed medical care because of cost and affordability, and 21%, 1 out of 5, put off filling a prescription due to this cost. And those are big numbers when you start talking about hundreds of millions of people who are putting off potential care. And that probably is compounded by COVID, where some people are not seeking access to needed care simply because of fears of COVID and COVID spread. So we have a real problem with the unintended consequence of cost sharing. As we move on. So now that brings me to the copayment accumulator. What is a copayment accumulator program? Plans stop counting the manufacturer's copay assistance that is paid on your behalf towards your deductible. So stop and think about that again. They stop counting the copay assistance towards your deductible. You can still get that assistance, but when that assistance runs out, you're now going to have to pay the deductible. Let me show you an example. Here's how a copayment accumulator works. There's a lot of verbiage at the top that assumes a plan, but let me basically tell you what this plan is. This is a plan where your deductible is, as a patient, $6,000, and you have a 25% co-insurance. So you're paying 25 cents out of every dollar for your prescription. So if we take the no copayment accumulator illustrated there in the purple box, basically the manufacturer's copay assistance pays up to $6,000. Well, that $6,000 means you've hit your copayment max, right? You didn't have to pay anything out of pocket because they paid out of your out-of-pocket proportion to hit the max. Now your benefit's 100%, so you don't pay any more out of pocket. The effect is the cost of, in this case, that $24,000 drug that we use here to illustrate goes down to $16,000 or $18,000 for the insurance carrier. So they're paying 18, the manufacturer is absorbing the other 6, and you as a patient have access to the drug at no cost. Now, remember, copayment accumulator doesn't count the deductible. So in the orange scenario, the copayment accumulator scenario, the manufacturer still pays that $6,000 of assistance, and you don't pay anything until that $6,000 of assistance, until that $6,000 reaches your maximum deductible. Then you have to start paying, and you have to pay your individual deductible, which in this case is $2,000. So you are now faced with a $2,000 expenditure you didn't have on this scenario without the accumulator. The effect, it reduced the cost that the payer, that is the insurance carrier, pays for the drug by $2,000 down to $16,000. So you can see you still get some benefit, but you wind up having to pay some yourself. And you say, well, if I haven't encountered this, is this really happening? And the answer is, these are data from 2020. Almost 60% of insurers had copayment accumulator plans in place by the end of 2020. Okay. And another 32% said they plan on expanding those programs. And as you can see, nobody in the bottom bar said they would be contracting those. So basically what you're seeing here is those that have these accumulator programs aren't going to change them, but those who don't have them are considering some kind of expansion. But, the next slide is called, but wait, there's more. Doesn't that sound like the infomercial? Let's take that same scenario, 25% coinsurance. You have a maximum deductible of $6,000. But remember, the maximum amount that the manufacturer is willing to contribute in copayment assistance for each individual patient is up to $16,000. Now, I know that's a stretch because I don't think most manufacturers would contribute 2/3 of the cost of the drug to these programs, but we do this for illustrative purposes because it makes the point. In this case, with what's called a copayment maximizer, the benefit plan requires not only for the manufacturer to pay up to your maximum out-of-pocket cost, that is to meet your deductible, they also require the manufacturer to exhaust the full amount of their potential cost subsidy. So in this case, that would be $16,000 out of that $24,000 drug. And you're still going to be required to pay your individual deductible of $2,000. So basically, this doesn't hit you as a member, but it does hit the manufacturer, which may ultimately mean, they can't afford as much per individual program. In essence, that could have the effect, and there aren't many maximizer programs in place, and there's even talk of legislating against these kind of things, but you can see there, the cost of the drug effectively to the payer can be reduced all the way down to a mere fraction, $6,000 out of the $24,000, or literally 25%. So these are things you need to be aware of. You need to be on the lookout for. There's not much you can do about them if you're in an insurance program that has one of these, but what it can do is maybe have you go back and have that informed conversation with your provider. Like, here's what I'm faced with. What choices do I have in therapy, and do I have equivalent alternatives that I may be able to access, for less out-of-pocket cost? And the reason for doing that is basically, you don't want to be that 21% that just doesn't get a prescription filled and therefore suffers the consequences of not being able to get your medicine. So keep that in mind, copayment accumulators and maximizers. So what I'm going to close out in the last few minutes I have with you, I know we're covering a lot of ground. I want to talk a little bit about telehealth. So as we look going forward here, what is happening with telehealth? Well, it was already growing before COVID-19. Again, these are data from some national data that shows that really telehealth was in its infancy, less than a decade ago. Back around 2013, just a tiny little fraction of visits or encounters with a provider were with telehealth. And most of them, or more of them, were in rural areas, and they were often encounters with specialists that you couldn't access easily. I'll give you a good example. Wyoming is our least populous state, but it's by no means our smallest state. And, perhaps if you live in eastern Wyoming and the only specialist that you might need to access, maybe a neuroradiologist, is in western Wyoming, you get your scans done locally and they're sent to a specialist in the western part of the state for a reading, and you have a consultation, or your physician, and you have a consultation with that specialist. And by 2018, which is the last year, up to a third of encounters had some telehealth component with them. And there was a bit of a flip-flop here, more urban than rural, and I think it was mostly because of access to computers, internet. Remember, there's still vast areas of this country, especially in those very rural areas, that still don't have great internet access. So let's look now at the impact of the pandemic. These are data from CMS, and it is a busy slide, but all you really need to do is pay attention to the black line here. And this is really just a 14-week period of time, I should say, from the onset of the pandemic last March until early summer. And if you really look at, what happened in telehealth visits, about 8 or 10 weeks into this, there was just a rapid rise in the rate of telehealth visits, which has been persistent. Also, there was a rapid decrease in the rate of emergency department visits for two reasons. One, they tended to be swamped with COVID patients. And two, many people were afraid to go to the ER for fear of exposure to COVID, or for the fact that they were so swamped with COVID-19 patients. If you didn't have a urgent reason to go there, you may be sitting in a very long line waiting for care. So the pandemic was the catalyst, really, that has driven an increase in telehealth. And that increase has gone on. But like most things, there's some pros and cons. It's not right for every patient. I know now I sound like a TV commercial. Check with your doctor if it's right for you, and I don't mean to parrot that. But there are a lot of good things in telehealth. It can cut costs for both you and the system. It can make access to care easier. It's easier sometimes to follow up with your doctor. It can be a time saver if you're one of those folks who has to drive a couple hours to see your provider or take public transportation in the circuitous route. It can be a time saver. Your provider can maybe involve multiple people on your telehealth visit. Spend 5 or 10 minutes with a doctor, maybe 5 or 10 minutes with a care coordinator or something like that. And doctors literally can reach more patients because they can be more efficient. The cons, it's not face-to-face, and sometimes there are just times when we as physicians need to be face-to-face with our patients, and patients need to be face-to-face with their physician. Sometimes if there are complex things that doctors need to explain, they need to have that give and take in that interchange. And there are other times when really, telehealth doesn't always easily cross some geographical barriers. You may not have good internet access. You have to travel some to get internet access. You kind of have eliminated the need. And of course, there's always that big concern at the bottom. We know that if foreign hackers can hack into the Pentagon, they can hack into virtually any medical system. And as you know, there are data breach compromises in health systems on a regular basis. So there are some concerns about privacy and security. But the good news is with the acts passed last year, the COVID emergency acts, Medicare now covers almost all services. In the past, you really had to have some justification for certain telehealth services, but now Medicare covers new patient visits. So, if you get referred to a specialist, you may be able to accomplish that entire new patient visit with a specialist. Certainly follow-up and established patient visits are covered. You can do just pure telephone consultations. Your provider may set up, not a Zoom meeting or something like that, which is a true telehealth visit, but just a short telephone conversation. There can be e-visits. These are things like questionnaire completions. Maybe you're a patient who has to fill out a standardized questionnaire about how your disease is progressing or doing. For instance, if you're part of a clinical trial, you might have to do that. And so these e-visits now have codes, and I don't expect you to remember the codes. There's also the concept of a virtual check-in. I'm sure many of you have seen. You'll get a note a day or two before your doctor visit and say, we need some information about you, and you'll fill out a questionnaire. have your drugs changed? Has your insurance changed? Have you been exposed to COVID? Have you had a fever in the last couple of weeks? And that virtual check-in actually is now considered a telehealth a visit. And of course, there's the scenario I talked about very early, evaluation of things like X-rays and those sorts of things. So, there's and commercial carriers have really followed this. So you don't have to worry about, well, gee, if I have a telehealth visit now, am I going to get a big bill from my provider because it's not covered? Medicaid really has followed along, even though that's state dependent. They've expanded Medicaid to cover larger populations. They've expanded the service that they provide to you as patients. They've even helped introduce technology in places like community centers and maybe even some high-risk patients to help them communicate, and have actually created some gateways to providers. So commercial payers, Medicare and Medicaid, have all made access to telehealth easier. So as we're moving, towards the last couple things I want to say, I will point out, as I've already said, commercial payers, basically allow the same things that Medicare allows, and even allow some audio-only phone visits. So I really think telehealth is here to stay, kind of as we look at the next slide. But do expect some changes. It won't probably stay the same as 20 and 21. Hopefully, as we move out, if we move out of the pandemic into 2022, we may see some of these rules change. There may be some more cost sharing put in for telehealth visits. There may be some new payment rules. I don't have a crystal ball. I don't know what they're going to be. But my message here is, be alert, be aware, ask questions of your provider, and ask questions of your doctor. When is it important for me to see you face to face versus when can I do it virtually? And so with that, I think I've used up all of my allotted time and maybe a couple more minutes, Stuart. So I was a little more loquacious than I maybe had promised initially, but I'll stop here and entertain questions.
You're good. You're good. Thank you very much. That was very, very informative. I'm hoping that everybody that has been online tonight listening to this gains something from this. And again, I'm going to say, if anybody has any questions, let's just click away online and ask your questions, and I'll read them off to the doctor. Also, please know that asking questions relating to COVID or the vaccines, directly wanting to know about anything to do with COVID, the virus, or about the vaccines and how it affects those with multiple sclerosis, is not relevant to tonight's topics that are being discussed. And Dr. Owens is not that kind of doctor that can answer this. He's the other kind of doctor of what he just did speak about. So we do have questions, and Doctor, I'm going to shoot some off to you, and you could ask away, and maybe others will have questions based on, from what you spoke about, and also leading up for or more to do with the questions I'm going to ask you. And the first one is, what insurance is good that you find for people with MS in Medicare, if any at all? What can you say about that?
Yeah, I by the way, Stuart, I love this part because it gives me a chance to interact with you in the audience. I think when it comes to deciding, what you want to do for supplemental coverage, you have to make a fundamental first decision. And that first decision is, do I want to be in traditional Medicare and get a supplemental plan? That's, decision point number one. Or, as you often hear advertised on TV, do I want to be part of what's called a Medicare Advantage plan? And a Medicare Advantage plan basically rolls Medicare Parts A, B, and D drug coverage together. So it puts them all together. So it's the same thing as traditional Medicare, plus your supplemental and your drug coverage D. It's effectively called Medicare Part C. And so that's the first thing you want to look at. The advantage of Medicare Advantage plans is one carrier covers everything for you, and the claims only have to go one place. You only have to deal with one set of rules and regulations. But these plans are a little bit more managed, so you may have to go through more prior authorizations or have more limited choices. On the other hand, you're probably going to pay a whole lot less out of pocket. The other downside to them is they're not offered everywhere in the country. There are certain regions where you may have a choice of no or only one or two Medicare Advantage plans. Now, let's fast forward. You stay with traditional Medicare, so you have parts A and B under traditional Medicare. Of course, Part B, you pay a premium for your Medicare Part B. If you're a Social Security beneficiary, that comes out of your benefit before you ever get it. If you're not a beneficiary, you pay that separately. You then have to get a separate prescription drug plan. And the best way to get the best one is not by name, but by looking at what these prescription drug plans offer, and are the drugs that you think you're going to need or need currently are on their formularies or covered by this plan. And CMS.gov does have a website that can help you navigate that arcane. And then you have to decide, if I want a supplemental plan, do I want to go with a local carrier like a regional Blue Cross plan or a national carrier? And again, there's no good, better, or best. It's almost like trying on shoes in a shoe store. A 10.5 in one store might fit me well. It might be an 11.5 in another store and a 12 in another one. You really have to do a lot of individual decision making. Now, there are patient advocates out there that can help you navigate these systems too. Community centers and many service organizations will have advocates to help you. So it is indeed a complex decision. I could spend the rest of the night talking about this, but those are the big choices you have to make.
So I want to add a little something into that, but thank you for that answer. Number one, the National Multiple Sclerosis Society and the Multiple Sclerosis Foundation and the Multiple Sclerosis Association of America all have their navigator programs that can help anybody, with, pointing you in the right direction and maybe being able to give you some information about this as well. What I'm going to say, though, is that I opted for Medicare Advantage, all right, and it's a PPO. And I thought, okay, that's great. Everybody takes PPO. Wrong. It's not that everybody, every one of those doctors that take Medicare Advantage work with the PPO, but not all doctors take the Medicare Advantage, which is another issue in itself. So they might take the supplement plan, but they don't want to take the Advantage plan. And I don't understand why not, but it's not for me to decide on. But, that's one of the things. But it is great that that I don't have to worry about Part D. But, a lot of people learn, though, about IRMA. Can you tell us about IRMA?
My knowledge of that is so poor that I would probably not be able to give a whole lot more than, defining the term. So, I better take a pass on areas that I don't want to wade into waters where I'm not comfortable. Well,
so if I give you a little bit of something on it. So IRMA is, I know a lot of people that are affected by it. They told me that they're having to pay an additional amount because their incomes exceed.
Okay.
Right. Okay. So that exceeds what they are getting from actual Medicare or the supplement policy. And because their incomes are a little bit higher, that they're now having to pay back. So their check that was for X amount of dollars is now being deducted an additional between $200 and $400 to either pay for, extra for their supplement and Part D or just for their Advantage. Can you explain that more?
Yeah, now I can. I did not, think about IRMA in the context of Medicare, but no, what you talk about is a very real phenomenon. Thanks to a congressional act a few years back, Medicare premiums became means tested, which is precisely what you're talking about. When I say means tested, if your income exceeds a certain threshold, your basic Medicare Part A and B premium, which is set every year based on a calculation of cost, goes up proportionally. And there are multiple tiers of that. It can go up, I believe, to this year, it's a little bit over $404 a month out of pocket, where I think the basic one is a little bit over $100. And that's good and bad news. The good news is if your income was such that you get into one of those higher thresholds, it means that you have, some extra income. The bad news is CMS has no idea, what your expenses are based off of that income, especially medical expenses, and so it can present a hardship. To the best of my knowledge, there is absolutely nothing you can do about that except to earn less money, which is not necessarily the best solution.
Right. So a friend of mine called me today. He's got that situation. And yeah, doing these programs, I have to learn a lot. So if anything extra comes up and our speaker doesn't know, at least I can, prompt them to know what it is that we're talking about. But my friend that called me about this today said it's not just him. All right. So because he files jointly with his wife, so her Social Security is also being taxed this extra amount. So it's not that they're losing $404 a month. They're losing $808 a month out of it. And, that's a big chunk. So is there, other than making less, is there anything else to do about this?
No, because Medicare benefits, unlike commercial insurance, remember, commercial insurance have family rates, right?
Right.
We have rates for, subscriber and spouse, or subscriber and domestic partner, or subscriber, partner, and children. Medicare is an individual benefit. And so all of us Medicare beneficiaries, I'm one as well, the issue there is all of us pay our individual portion. There's no real simple way to do it. I'm not an accountant. You might be able, if each of you have income and you file jointly, and that joint threshold pushes you over that limit, you might be able to file separately, but then you have to talk to your accountant, because filing separately, you may lose elsewhere and wind up paying more in the end. Of course, you can get a divorce and just live together. And
That's right. That's right. All right.
But it's not a real practical solution.
Great. Thank you for that answer. I have more on paper that I'm going to ask. I'm letting people know that are asking questions online that I will be getting to your questions as well. Just know that you're just going to have to wait a few minutes, because we have to do those that wrote in first. Okay. So the next one is, do you have any successful tips for applying for, I guess they said disability, but I guess they may be referring to Social Security disability. I don't know if you could answer that.
I can give you some general aspects of it. Certainly many MS patients qualify for Social Security disability. The best tip I can give you is be persistent. A significant number of initial applications for Social Security disability, unless you have some overwhelming catastrophic illness, such as you're rendered quadriplegic in an auto accident, to use an extreme case, get turned down. But persistence pays off. Much like I talked about appeals for getting drugs, which is a simple appeals process, there are appeals level, multiple appeals level for disability. So the first thing is document. Make sure you provide as much or more information that you think will be germane to the application. If you do get turned down, again, seek assistance. There are legal specialists who specialize in Medicare disability. There are advocacy organizations that specialize in disability. If you can't afford an attorney, I don't know, Stuart, you may know if the National MS Society may have, anything like that. But mostly it's about being persistent. Because they say no the first time, don't give up.
Right. All I can say is that, if you're with a good attorney that does Social Security disability, that person may not be able to get it for you the first time, but should be able to get it during a re-review of it. So, you just have to know that you can't be working at all when you're applying for this. And that's the biggest problem, is how you're going to afford what's going on. All right. But you have to be able to sustain yourself during that time. Okay. So, all right.
There too, because once you are on Medicare or Social Security by disability, you also qualify for Medicare. So your premiums are going to come out of that benefit.
Right. So I was just reminded that most Social Security disability attorneys do things nationally. So regardless of where you are, you can find somebody that's in New York that and might be able to help you if you're in the state of Washington. All right. But you just have to, go by word of mouth, I guess, and finding out who you can use. And for that, you can contact any of the MS organizations, including MS Views and News. All right, next question. Next question. All right, we got a lot of them coming in now. I'm interested in learning how to best take advantage of Medicare, et cetera. Signups as I'm nearing that time. Like, should I be on disability until I retire to take best advantage of SSI benefits?
Should I be on disability until I retire? I'm a little confused there, because if you are on disability now, then aren't you by definition not working? Because that gets back to that question. Is the fundamental question perhaps, do I apply for disability first and then wait till I age into Medicare?
I see what you're saying. After reading the question again, it says, like, should I be on disability until I retire? But yeah, you're supposed to be retired already if you're on disability, right?
Yeah, it's mutually exclusive.
All right. So if whoever asked that question when you registered for the program is online listening right now, if you can rewrite that, that would be great. And then we'll hit on that a little while, okay? All right. Next one is how to best know if Medicare Supplement or Advantage. I think you already spoke about that. You already spoke about the IRMA. All right, so we'll skip that one. Next one is can you please include a discussion of the drug tiers and the formularies, maximums for the prescriptions with Schedule D or versus Advantage?
Yeah. Basically, all Medicare plans have to offer multi-tiered formularies. That's required by the statute. A typical Medicare plan has a 4 or 5 tier structure. The first 2 tiers are for generics, and they have what are called preferred generics, which often come to you at low or no out-of-pocket costs, $5, $10. Some of them even have zero copayment. The second tier are non-preferred generics. And you say, well, why would you have non-preferred generics? Well, we've really entered into a world where some generics are as expensive as branded drugs. So, those drugs now will carry with it usually a copayment, and that copayment can go, $30, $40, $50 for the copayment. Then you have 2 tiers of brands, typically the preferred brand, where the typical out-of-pocket cost for a Medicare beneficiary is $30 or $40, and a non-preferred brand where it can go up to $65 or $70. And then the specialty tier that can be, Medicare allows co-insurance all the way up to 33%. In terms of what plan is going to be best for you, you really, again, have to do your homework and look at, okay, does my Medicare Advantage plan, what are the different tiers on their formulary, and where do my drugs fall? Again, that's those websites that you can go to or seek assistance. And you have to look at, okay, does plan A over on the Advantage side or plan B on the Part D side paired with my supplemental, offer the lowest out-of-pocket cost. So again, there's no magic formula that you can just say, do this or that. It really becomes a unique circumstance for almost each patient, which is why when the statutes were created more than a decade ago, when Med D launched, they required these websites and assistance tools, modeling tools, be part of the system to help people navigate through this complex area.
Okay, thank you for that. So when you were doing your discussion, did you talk about plain Medicare and then the reasons for taking supplement or an Advantage plan?
No, I talked about that, in the question that you answered, but no, that was not part of the talk. We didn't get into Medicare. I stayed focused much more on drugs and out-of-pocket costs for drugs, and then a good amount on telehealth.
Okay, because somebody is asking if you can explain why they should go on to a supplement or an Advantage rather than just taking what's given to them at 65 or with disability, about just getting their Medicare card.
Okay, so yeah, if you get your Medicare card, that will include Part A, which is hospitalization, home health care, skilled nursing care, that sort of thing. Part B Medicare covers your outpatient services. Now, what happens if that's all you take? Well, number one, you don't have drug coverage because that's Part D. And if you delay in taking drug coverage, every year you delay, you pay a penalty when you do enroll. And what's most important, Medicare Part B is a co-insurance plan. It is by statute since the inception of Medicare in July 1966, an 80-20 plan. So Medicare only pays 80% of the allowable. So let me give you an example. In Medicare, if the service costs $100 and it's a Part B service, and Medicare allows all $100 of that as an allowed charge, Medicare is going to pay 80, and you're going to pay $20 out of that. And so that's why you take supplemental insurance or go into Advantage, because, okay, for $100, it's probably not a big deal. $20, may not be a deal breaker. But let's say you roll up an intravenous infusion bill under Part B that's $10,000. 20% of $10,000 is $2,000. And let's say you have to get that 4 times a year, that's $8,000. And, just taking Medicare Part B, that's going to happen to you over and over again. There is no out-of-pocket limit in Medicare Part B.
Right. Thank you for that. All right. So one person wrote that when you're on disability, that you can still work. And I don't know if you want to comment on that.
We are definitely getting way outside of my knowledge of
Okay.
We weren't a disability insurance carrier. You have to know a little bit about it to know when people's benefits kick in. I guess that implies there's some level of means testing, but beyond my scope, Stuart.
Okay, not a problem. I would want to comment on that. Again, I am not a professional. I'm just going to say something about this. All right. I do know that if you're applying for Social Security disability, you better not be working when you're applying for this. Right. You may get it and then find a part-time job and want to make a few bucks. But if they catch you doing this, you're going to have a big problem, especially if you go over a certain amount. So I'm going to tell everybody that if they are applying for Social Security disability, and if they do get it, make sure you speak with your attorney about anything that you may consider as finding part-time work, and the amount that you're allowed to make per state, I think, is different. So you really got to watch out for that. Okay. And again, I'm not a professional. I'm just telling you from what we've learned over the years by doing these kinds of programs. Okay. All right. Next. Oh, now a person writes, the same person, you're right, but whatever. All right, we'll go into something else now. All right, so another fear that people have is how does the Medicare system know when you're going to visit your doctor and you pay your copayment or out of pocket, whatever it is? How do you know that doctor's office is reporting to Medicare the amount that you're being charged in copay? So that way it comes from so that it works against your overall out of pocket for the year.
Yeah, well, you don't even have to know, because when the doctor submits the claim, if you have a subscriber liability, they will automatically, their system set up to automatically adjudicate the claim and deduct from that what the member should have paid, which is precisely why many doctors require you to pay your copayment at time of service. In fact, some doctors even say, okay, you're going to see the doctor now. Can you please provide us with a credit card to pay or cash to pay your copayment? Because again, let's use that $100 example. And if your cost is $25, Medicare is going to adjudicate the claim and pay the doctor $75. They're not going to pay the whole claim. So if the doctor hasn't collected your portion of it, it's now on that doctor, he or she, to collect that money from you. So, Medicare knows because they never ever pay what's the subscriber or member liability in their claims.
Okay, thank you. All right, Michael wrote in a question. He says, once awarded SSDI, do you automatically get Medicare even if you're not 65?
That's my understanding. Stuart, I recognize roughly, what is it, maybe 6 or 7% of Medicare beneficiaries are disabled again. That was an expansion of the original 19 66 Act. And I believe yes, because once you get disability, which means you are by definition a Social Security beneficiary, that triggers your Medicare application.
Okay, thank you for that. Telehealth, let's switch out a little bit and then we'll come back to Medicare, all right? Telehealth, is this something that the insurance companies will begin covering nationwide, or meaning that in the past it's only been that you had to use a doctor within your state? Okay, will this, so for COVID, they accepted that you could use a doctor anywhere in the United States and that you'll be covered, but will this continue post-COVID? Have you heard anything?
That's one of the things on that closing slide that we don't know yet. We relaxed a lot of rules for COVID because of the necessity of doing that and recognizing a lot of people cross state lines for medical care. The problem going forward is if we get past the pandemic, a lot of licensing rules, state licensing rules, don't allow physicians to practice across state lines, because when you're in an office, you can get patients from any state because you're practicing within the confines of that state. Now, fast forward, the area I live in, Mid-Atlantic, Maryland, New Jersey, Pennsylvania, and Delaware all can be reached within, if you're in the right spot, within a 30-minute drive of each other, depending on the direction you go. And the question then is going to be, and I don't think we know yet, will state licensing bureaus allow people to do telehealth visits, which are essentially a provider encounter across the state line without licensure in that state? And I don't think that has to play out yet. Or will they build some kind of reciprocity for telehealth? Maybe. But the state regulators also get concerned. If we do that, are we going to run into problems with physicians who maybe aren't practicing appropriately, or who violate some kind of regulation? What jurisdiction will we have if they're not in our state and not licensed with it? It gets really complex. I mean, we simplify things for COVID, but the pendulum is definitely likely to swing back the other way as people begin to think about the details of this.
Okay, thank you for that. I'm going back to Medicare. Let's include now Medicaid. Is there a waiting period? Is the waiting period for Medicaid different than Medicare?
That varies. There are 50 variations on that because there are 50 states for Medicare. Every state has individual regulations on, number one, Medicaid eligibility, which we hear a lot about in the news because a lot of states have expanded Medicaid eligibility in the wake of COVID. They also have different waiting periods. For instance, I just had a friend who had a relative who was uninsured and encountered a sudden and catastrophic illness and was, had no insurance, but also had very few assets and therefore was Medicaid eligible. In the state that they were in, which happened to be Massachusetts, Medicaid eligibility occurred as soon as the application was approved. They were able to get it in almost 48 hours. But I can't guarantee you that happens in every state because, the old adage, when you see one state Medicaid plan, you've seen one state Medicaid plan.
Okay, thank you. All right, Bruce wants to know, I got to get back up to his question. Most drug companies will help in co-payment, but not if government healthcare such as Medicare. What should we do to find a co-payment? What should we do to find co-payment assistance?
Yeah, when you are insured by a Medicare, yes, you are absolutely correct. The Medicare statutes bar manufacturers from providing co-payment assistance because that is called technically an inducement. And an inducement is is barred by the statutes. The only thing a pharmaceutical company can do, or you can do, is apply to 501c3 foundations, which get unrestricted grants from pharmaceutical manufacturers, and then are able to dispense those grants for people with certain diagnoses. For instance, there's things like the National Organization of Rare Diseases and HealthWell and Patient Assistance Foundation, Patient Access Network Foundation. All of these are 501c3s, which mean they qualify as charities. They take money from the pharmaceutical company. The pharmaceutical company remains hands-off on how that money is managed, but it's not hands-off because the Office of Inspector General, the OIG, certifies and regulates these organizations, and they have to meet very strict criteria for how they manage these grants. They're all means tested, which means you have to have income that's below usually a certain multiple of the FPL, the federal poverty level. So typically it's 3, 4, or 5 times the FPL to qualify. They also have limited funds. So if they get more requests for assistance than they have funds, they often run out of these monies, sometimes very often early in the year, and you wind up in a long queue. And the rules change. The OIG is a bit fickle. They change the rules fairly often. So, you know, and what that means is you may not be able to get assistance for your specific drug. You'll get assistance that will cover drugs used to cover your specific disease state, in this case, MS, and not every foundation has MS funds. So your options are very, very limited unless you have a rich uncle.
Right. So Jane is responding to what you're saying, that I've done tons of research, and most or all foundations have income limits. She believes like about 130,000, and that's more meaningful, meaning that the 4 times multiplier that the doctor mentioned, the four times multiplier, isn't that 4 times greater than the poverty level?
Yes, yeah, that's exactly what I'm talking about. Most of these foundations, I actually worked with one for many, many years. They would base their eligibility for assistance based on the FPL, the federal poverty level for a family of 4, and then apply some multiplier, typically 3 to 5 or 3 to 6, and it varies depending on the disease state.
Okay, thank you. And
so
then
I mean, go up over $100,000 because I believe the FPL for a family of 4 somewhere around 20-something thousand. So you multiply that by 4, you're over 100K.
Okay. All right. I have no idea. So I'm at your mercy. And whoever else is answering this right now, that's great. Thank you for that. Listen, anybody, you're online. It doesn't mean you only have to ask questions. If you have input, that's great. We want to, we're going to include that too. So Myrna is also saying, though, that Medicare, Medicaid, they wait 24 months in hopes that you're going to miraculously recover and not get it. We're talking about exactly. And that, even after 7 years, they're going to ask you to, they're going to send you a letter saying that they want to reevaluate you. And believe me, it even happens after 7 years, because I know many that are on it 20 plus years, and they're being reevaluated every certain increment of years. And sometimes they even watch to see what you're doing in your front yard or backyard. All right. Okay. All right. Before I ask another question here, I just want to remind everybody that next week we have 4 virtual events happening next week. On Monday, we have our Moving with MS series, which is our physical therapy. All right. And then on Tuesday, we have mental health with psychologist Rick Harris. All right. And if you've never heard Rick Harris, you really need to listen to Rick Harris. All right. He's a know-it-all of everything to do with mental health and concerning multiple sclerosis. All right. He's been working with us for 10 years now, and he's got it down pat. So we really would like you to join in on that program. We'd like you to join in all the programs. All right. But that's a very special one. And then on Wednesday, we again have MS Patients Voices, which is me just speaking with multiple sclerosis patients. All right. And Damian Washington and I will be interviewing a lady from the New York City area who's going to be speaking about mental health, but getting more so into depression and how that is related for multiple sclerosis patients. And maybe she'll talk a little bit about suicide and what they're doing to prevent that, okay, for multiple sclerosis patients, because so many are so affected by the disease, and then adding in the economic factors as well, and COVID and everything. There's just been a mess of stuff happening this year especially, and going into last year. So she'll be around to speak with us about this. All right. And then on Thursday, we have the MS Hub series, which is the MS Advocacy Hub, where I will be interviewing the people from the Consortium of Multiple Sclerosis Centers, which is basically nurses, all right? But they're involved with what's happening with the patients. So they're a nurses organization, but because they're more in tune with what is happening with MS patients around the country, they're going to bring to you all the resources that they have and that they're doing for people with MS. All right, so I want to let you all know about that. If you want to know about it, you're not registered for the series, the different series already, then go to our website, msviewsandnews.org, okay? And in the center column, there's a list of all the programs that are upcoming and happening soon. All right, now let's go back to a few more of the questions that we have. Bill is asking, does Medicare use a copayment accumulator?
Yep, that's an easy one. No, by law, they're not allowed to do that. Medicare Advantage programs that have a formulary and Medicare Part D programs are not allowed to use copayment accumulators. So these occur mostly in commercial plans, and many of them are in those commercial plans that are what are called self-funded, which means if you're employed, your employer is actually paying the cost of the claims. And part of these copayment accumulator programs were put in because employers were looking for ways to manage the costs that they have on behalf of their beneficiaries. So this lives over on the commercial side. By definition, it doesn't occur in Medicaid because any out-of-pocket cost in Medicaid is quite modest. In most states, it's either $0 or $1 or $2 or some modest amount. So you accumulate. I can't talk plainly tonight, Stuart. You encounter these in the commercial insurance. And by the way, hearing all your programs, which are great, that's an outstanding endeavor, but it makes me tired just listening to how busy you are.
So yeah, talk about busy. We have 11 events in June, 11 events in July. We have 9 events, I think, this month. And so, the beat goes on. We're trying to do and bring to the MS community, there's something for everybody. Yep. So, we have all these different programs each month. And again, there is something for everybody and there's just thousands that are watching these things. So, if you're not part of it, you should be. Okay. And that's all I can say about that. All right. Next, Stephanie is asking, what's a good resource for disability?
I think it's the same resource, we talked about in a couple other questions. It's almost one of those don't go it alone because it's a very complex and arcane area. Stuart has talked about, seek out attorneys who specialize in disability, service organizations. Stuart has pointed out some of those, can point you in the right direction. Ask other MS patients, how, or with whom they were affiliated. There's some public advocates that can help, but this is a complex area, you really do, unless it's just a slam dunk disability. You need an attorney who knows what they're doing.
Great, thank you for that. Yes, if you're thinking about going on disability, you can contact us, me, or the MS Views and News organization, and we will give you names of attorneys that do work nationally. In fact, we have one that is speaking for us in July, I believe. His name is Stephen Stepper. He is from South Florida, but he will work with anybody anywhere in the country. And we do have other Social Security attorneys that work with us as well that we can give you their names too. All right, so thank you. One last question, all right? We have one last question. And I'm sorry for the tissue, everybody, but it got cold in here, really cold. The air conditioning is freezing in here. It's really pumped up hard. And I feel like it's January again. All right. So the question is, and this is a good one too, and they're all good, but this is one that somebody asked me recently and I had no idea how to answer. If you're on Social Security disability and you hit the full retirement age, do you switch over automatically to SS retirement, Social Security retirement. So does your SSDI switch just to Social Security retirement when you reach the full retirement age?
My understanding, well, you have to separate full retirement age from Medicare because you become Medicare eligible at 65, right? The full retirement age now is a number above 65, depending on the year you were born. So there's two different eligibility levels there. And you don't have options like you do with Social Security to take an early retirement at age 62 at a reduced benefit. So my understanding is that when you turn age 65, you become a traditional Medicare enrollee. That's my understanding. And the difference is really nothing because the benefits are the same now. What I don't know is there any difference in the out-of-pocket cost between when you're on disability and when you reach the 65 and convert to Medicare? And I just don't know the answer to that.
Okay. So for that, Michael, I'm going to suggest that you contact a Social Security disability attorney and ask them that question. It's not going to cost you anything to call one of them and ask, okay? So that's it. I think that, here comes another one. SSD, is there a 20-month wait to go on Medicare? Just looked it up. Oh, it's okay. So that person is saying what a lot of people have said, that there is a 24-month wait, except that I think that if you're a special condition, you can get it a lot sooner. Is that not true?
Yeah, that again, the disability side of the world is probably not my best expertise. I can attest to that. And these are great questions because disability is so intertwined with many MS patients that it makes the situation more complex. I wish I were more of an expert in that, but that's yet a whole nother area. When I worked for the Blues, we had a whole separate company that handled disability and a whole separate group of medical directors dealt with that.
So I got 3 different people saying no, that you got to wait 24 months to get Medicare. And yet I know somebody in Miami who, right after she was approved for Social Security disability, she got Medicare immediately following, within a month. So I don't know if there's a standard and just that I can't say that there's a standard if I know at least one person that got the Medicare benefit right after getting approved for Social Security. I don't know, everybody. I guess you'll have to wait till July and we have a Social Security disability attorney online. Then you could all come back and ask them all those questions that unfortunately Dr. Owens cannot answer today. That's right. And even Dr. Owens will come online to learn more from that, okay? All right, great. So I want to thank everybody for being here. Again, if you're not registered for our upcoming programs, please visit the MS Views and News website. Look at the center column, okay? And that's what's happening during the current month, all right? And you can look on the right side of the website page to see what's coming up in the coming months, all right? And we are adding programs and adding programs and adding programs, and we are beginning to do hybrid, okay? And hybrid, a new term for what used to be doing a live program with a live stream, all right? Now it's doing a virtual program live and in person, and that's the hybrid, all right? And we're starting with that in June 12th. I will be in Columbus, Ohio with Dr. Aaron Boster doing a live in-person program it's a socially distanced program. We'll be doing that hopefully in July in Jackson, Mississippi, okay? Hopefully in August in Virginia, and the beat goes on. We are going to be scheduling these events to start happening once a month in various rural locations or suburban areas, but not in urban areas, all right? I don't want to be around too much of what is still out there, okay? So again, we wanted to thank Dr. Gary Owens for being here. Thank you very much. And I want to thank you, all of our guests, for being online. And I hope you all have a great night, and I hope to see you all soon. Be well, everybody. Thank you very much. Ciao.
Thanks, Stuart. Thanks, audience. It's been my pleasure.